So my name is Sabrina. I'm the current simulation teaching fellow at Epsom and Helier in South London.
And I'm Dani. I was the simulation fellow for the past 6 months until Sabrina took over.
So we can answer any questions about the future as well of this course. So the crisis course, different to the emergency medicine crisis course that was spoken about earlier, this is about the care, recognition and initial stabilisation in simulation of patients. This is same name, different context.
Yeah.
It's an interdisciplinary, multidisciplinary simulation course that's mandatory for the nursing staff and healthcare assistants at Epsom and St Helier that they have to do every 3 years. And the idea is this course allows them to work together to manage an acutely unwell patient, whether it be a surgical patient and or a medical patient, just anybody you'd find on a ward in an ED setting. So in the past we've looked at the quantitative data about post and pre and post confidence scores, but this time we thought we'd look a bit more at the qualitative responses, particularly of the courses over the first 3 years that they've been run over. So we had around 400 people through over the 3 years, and of these 400 people, when they looked at what did they want to come and expect from the course, if I draw your attention to the bottom of the poster, really the pre-course expectations or hopes really were managing the sick patient, and we knew we're touching upon acutely unwell patients. They wanted to improve the interpersonal skills, which makes sense because it's an interprofessional simulation day, and they really wanted to look at common clinical scenarios. The reason why this course was designed initially was because of incidents in the trust, and it was a way of improving patient safety or having a better safety culture in the trust, and they felt the majority of safety concerns were to do with interprofessional aspects which could be improved upon. So we had 400, and the 3 key themes in terms of pre-course expectations were, for us as expected, as faculty, and we looked at the post-course text responses in more detail, and really it all centred mainly upon human factors and what they took away from it, which they could use in clinical practice. It does help that our debriefing tool is the Diamond debrief tool, which really focuses more of the time on exploring how they're feeling, how they work together. Really comes out most, so focusing on human factors less so than the technical aspects, because that seems to be more of the factors which are involved when you improve scenarios or improve clinical situations that don't quite go as planned and have adverse patient outcomes. If you improve the human factors, you tend to improve patient safety, particularly in our trust. So fortunately, the post-course results matched. The post-course take-home messages were human factors based, mainly to do with sharing the mental model, communication, teamwork and graded assertiveness were the 4 key themes that came out in the post-course text responses. Equally, people shared thoughts on the course itself, as well as what they took away from it. They found that they loved the course idea, and they loved the interdisciplinary nature of it, which met their hopes, but also they felt they wanted more. So we provide them 3 times a month, is really the maximum that we provide. We have 14 people at one time, but we can't always get everybody to be released from their work rotas. So we need to have a lot of buy-in from the line managers. So sometimes the line managers will schedule people in themselves, saying, oh, I can release these people in for their mandatory training, or people will have to book it in themselves and ask for study leave. We give them a bit of flexibility. So the departments where it works better for the line manager to do it, they can do that. The departments whereby the staff themselves want to do it, we allow them to do it by having an online platform for booking. So we use Eventbrite now, so we allow them to book onto it, which allows them to do it as often as they want and to fit it with their own timetable. But really another point that came out from the open comments was the relevancy of the scenarios they felt could be improved. That's because we feel a trust-wide simulation program for all nurses, all healthcare assistants and across the board, and doctors. So sometimes you might have a lot of ED nurses, we might have a lot of surgical nurses, we have an orthopaedic suite, and therefore the scenarios for some might not feel as relevant as if they had a personalised day for ED. However, what we try to do is show the expectation is the human factors are transferable, no matter if you work in ED or if you work in orthopaedics or if you work in surgery or general surgery.
Yeah, the take-home messages were the same. They were all seeing the improvement in the human factors themselves. And that was the basic outcomes that we got from this particular investigation that we did. Any questions?